Hey there, N457 students. This is Paul Mazurek. I was the guy who gave you your shock lecture, I think a couple weeks ago now. And one of your classmates, Micaiah, boy, I hope I pronounced that right, was asking me about preload and particularly on the differentiating between the right side and the left side, as well as differentiating shock states. So what I thought I would do is just take a quick 5 minutes to try to explain it. The first thing that I'm going to do is explain it from the setting or the concept of the Swan-Ganz catheter. Now, from what I understood, you guys didn't get a lot of discussion or instruction on the Swan-Ganz catheter itself because you just don't see them that much. While that's true, there are some very important concepts that you can learn from these parameters, so we are going to talk about that. With respect to the Swan-Ganz catheter itself, it's inserted usually in the subclavian or internal jugular vein, and the catheter has a balloon at the end, and when that balloon is inflated and you get the catheter into the right atrium from the superior vena cava, it starts to float its way into its final destination, which will be the pulmonary artery. So as the balloon is inflated, what we'll do is we'll look on our monitor and we'll see distinct waveforms. So this first waveform that you're going to see is the right atrial pressure. Another name for that is the central venous pressure. Now, the central venous pressure is what we use to determine right-sided preload. And again, when you think preload, think fluid. So when you think preload, think fluid. So we're going to talk about the right side and the left side of the heart. Typically, that pressure for a normal adult is going to be about 2 to 6 millimeters of mercury. Now again, as that pressure rises, that means there is more preload on the right side of the heart for whatever reason. Fluid overload or the right ventricle not pumping well enough. Either one of those can cause an increase in right-sided preload. Now what we're going to do is we're going to thread the catheter through the tricuspid valve, and you're going to see a change in pressure and a change in the waveform because now the catheter is threaded through the right ventricle. Now what we're doing is the catheter is floating into the pulmonary artery, and you're going to see another change in pressure, and it's going to look like an arterial pressure waveform that you should be familiar with a dichrotic notch. This number is going to have a systolic and a diastolic pressure associated with it. Typically, the systolic pressure is about 20 to 30, and the diastolic pressure is about 10 to 15 millimeters per mercury. And again, this is just based on the textbook that you read. The numbers are going to vary. Now, as the balloon at the end floats the catheter, it's going to what we call wedge or occlude into a distal portion of the pulmonary artery. That's what we call our pulmonary capillary wedge pressure or pulmonary artery occlusion pressure. Those are both the same values. And again, depending on the textbook that you read, that number can be anywhere from 4 to 12 millimeters of mercury for a normal. And what it's doing, if you look, the catheter kind of has an eyeball at the end of it, and it can see distal through the distal portion of the pulmonary arteries, and what's at the other end of that. The other end of that is the left atrium. So that's where we can get our left-sided preload. Again, preload, fluid, and we can get an eyeball view into the left atrium. So this number is very valuable. Now watch what happens when the balloon is deflated. The catheter is going to drop back a little bit, and you're going to get a change in waveform again back into a pulmonary artery waveform. So you're going to get your systolic and diastolic pressure. So if you understand where we get these numbers and what they represent, again, this is all fluid pressures, and we're talking right now mainly for the purposes of right-sided and left-sided preload. Now we can start talking about how we're going to differentiate shock states based on clinical presentation and based on what we see with these numbers. More importantly, the clinical presentation and your assessment skills is what's going to be the big determining factor with respect to differentiating shock states.
So remember, as a review, with respect to stroke volume, which is part of our cardiac output equation, we have preload, afterload, and how well the heart squeezes. So far we've just talked about preload. Now we're going to talk a little bit about how afterload and how cardiac contractility or squeeze play into cardiac output and ultimately the delivery of oxygen to the tissues.
So one thing that I would like anyone who's watching this video to do is to go to this article. This was an article that I referenced when I gave the discussion a couple of weeks ago. You can find it, I believe, in your list of articles on the Canvas website, but also you can go to the electronic version through the Taubman Library. And the advantage of doing that is you can click on some of these pictures, and one in particular is this interactive graphic here at the top. So if I click on that, what it'll give me is normal circulation and then go to types of circulatory shock. So for example, if I pick hypovolemic shock, what it'll show me is why it's occurring and then signs of that along the circulatory pathway. And it will show me what it does to central venous pressure, what it does to afterload, what the signs and symptoms are, and things like that. So I can really get a good idea of how shock, the different types of shock, are differentiated based on etiology. So I would encourage anybody who is viewing this again to go through this article, and if after that you have a really hard time differentiating between shock states or understanding shock, then I will be more than happy to sit down with you. But this is probably the best article that I can think of over the last 5 or so years on shock in and of itself. So I would really encourage you to go to this article. So hopefully this slide looks familiar. In differentiating shock states, it's important to understand it from a hemodynamic parameter standpoint and, more importantly, a clinical exam standpoint. So again, when we talk about preload, afterload, and cardiac contractility, we're talking about stroke volume adding to cardiac output. So if we look at the different shock states, for example, hypovolemic shock, it makes sense that if we have less fluid, we have less fluid pressure, therefore less preload. So left and right-sided preload will be reduced. Now, when we get to afterload, because we have a reduction in the amount of volume as a compensatory mechanism, the vasculature distal to the left ventricle is going to constrict, increasing afterload or increasing systemic vascular resistance. Again, afterload is that amount of resistance applied distal to one of the chambers of the heart. We usually talk about it from the standpoint of the right ventricle or the left ventricle. So that means that that particular chamber, if the afterload is increased, that particular chamber is going to work harder in which to move blood forward. And in which case, if our preload goes down, that means our left ventricle is having to work harder, so therefore our cardiac output goes down. Now, what do you see clinically when you see a patient with hypovolemic shock? Typically, you're going to see the lung sounds are going to be clear, right? Because there's not that much fluid pumping through the heart. And the patient is going to be, could be cold and not feeling, you're not really going to feel much in the way of peripheral pulses because of the increase in afterload. Compare that to cardiogenic shock, where you're going to see the same type of symptomology from a clinical standpoint, because you see the vascular resistance goes up in both types of between hypovolemic and cardiogenic shock, as well as the cardiac output ultimately going down. But what the difference is you'll see an increase in the pressure on the right and left side of the heart, the preload on the right and left side of the heart, because the left ventricle isn't able to pump as well, and so fluid backs up into the lungs. If fluid backs up into the lungs, lung sounds are going to be different, obviously, between cardiogenic shock and hypovolemic shock. If you were to look at the patient's monitor, you would probably see similar monitor readings. You'd probably see tachycardia. You'd probably see a low blood pressure, or possibly see a low blood pressure. So in differentiating between these two, we have to do a full clinical exam in order to really get a good idea of what's going on with this patient if we don't know the history and if we don't know other situations. Now, if we look at distributive shock, what you have is, because of the inflammatory mediators and the fact that the capillaries are getting leaky and they're also getting bigger, you have a larger set of pipes, which gives you a relative hypovolemia. Haven't really lost a lot of fluid, but the fluid that we have won't fill the size of the piping system, so to speak. So what happens is, initially you'll see a drop in your preload. Initially, what you'll see, because of that inflammatory response, you're going to see a drop in systemic vascular resistance. So your afterload is going to go down. So the patient clinically will be warm. You may actually feel bounding pulses peripherally. And because of that, there isn't a whole lot of resistance that the left ventricle is pumping against, so cardiac output is going to go up. So that is a big differentiation, both clinically and what you may see on a monitor, between cardiogenic and distributive shock. Eventually what happens, and we talked about the difference between quote-unquote warm shock and cold shock in class. One of your classmates asked the question. What eventually starts to happen is you start to see an increase in afterload because of myocardial depressant factor and other situations where, if you're applying pressors to the patient, you're going to see an increase in afterload. So then what starts to happen is you start to see systemic vascular resistance going up. What probably will happen then is you'll see an increase in your right and left-sided preload and a decrease in cardiac output. Well, what does that look like? That looks exactly like cardiogenic shock. So, and as far as obstructive shock goes, I'm going to let you try to figure that one out on your own as to what you may see and why. And again, if while you're trying to figure that out, you run into a roadblock, you just can't get it, give me a shout. So hopefully this helped. And I look forward to other emails or any other questions. I think I'm starting to get these because now you guys are starting to see that shock is going to be a big part of your next exam. So good luck, and again, if you have any questions, give me a shout.